I'll keep going. So first things first, can everyone see the screen? If I'm standing here, can everyone see?
Yep.
Okay, so the prostate. So I don't know if you guys are familiar with social media, but there was a poll recently on Twitter asking men if they knew what the prostate was, where it was, and what it did. And there were about 70% of respondents that actually had no idea where it was, what it was responsible for. And so I thought I'd begin by trying to demystify that. So in essence, the prostate gland is part of the male reproductive system. We only have one of them. It's a small gland. It lies deep within the pelvis and it's sandwiched between the pelvic floor and the base of the bladder. The role of the prostate normally is to produce fluid. It produces secretions that are found in a man's ejaculate fluid, and it's there as supporting fluid. It provides nutrition for the sperm. It is a pretty small organ, and there are three main conditions that affect it. It can get bigger as we get older, and that's pretty much universal. Whether or not it affects a man to a greater or lesser extent is another factor. But one thing is for sure, the older we get, gradually, progressively with time, the prostate gland will get bigger and more than likely will cause some dysfunction. The prostate can become inflamed, and that tends to be characterized by pain. And there's also prostate cancer that is far more common as we get older. So if you have a look at the next slide really highlights, this is data from Australia, and this is going back, this is the most up-to-date data that we have. This is looking at 2014. You can see the most commonly diagnosed cancer in Australia is prostate cancer, ahead of breast cancer, with over 18,000 cases on an annual basis. If we look at now the mortality rate from cancers, and this data is from 2016, you can see that lung cancer is still the #1 killer in terms of cancer deaths, followed by colorectal cancer, and in third place is prostate cancer. So breast cancer, and there's a big national screening program for breast cancer that we're all aware of, but still today breast cancer causes fewer deaths than prostate cancer does on an annual basis. Yet there still remains this uncertainty about whether or not we should be testing men for prostate cancer, and part of the dilemma really is that there is a difference of opinion between what the College of General Practitioners advocate and what the Urological Society of Australia and New Zealand advocate. So if you go to your GP, you may get a different advice with regards whether or not you should be screened for prostate cancer than if you went to see a urologist. And I'll try and get to the bottom of that as well. So many of you will be aware that the way that we screen or test for prostate cancer, now the purpose of that is to try and pick up cancer at an earlier stage where it's more amenable to treatment. And the cornerstone of how we've tried to do that over the last 2 to 3 decades has been with a blood test, the PSA test. Now there are some problems to the PSA test. The problems really are that it's not specific. So only the prostate will produce the PSA, but there are different conditions that affect the prostate that can push the value up. So if your prostate is big, or if your prostate's inflamed, or if you have an abnormal growth, any one of those three, or a combination of those three, can cause an escalation or an elevation in your PSA test. So getting to the bottom of if a PSA is abnormal can, in certain circumstances, be a little bit tricky. I see a lot of guys that come and see me and they say, "No, doc, I've had my PSA, it's normal." There's no such thing really as a normal PSA, because we look at a lot of different aspects to the PSA. Does everyone here know what their PSA is? Anyone not know what their PSA is? Normal, okay. Yeah.
No problem.
Yeah.
1.6.
Okay.
Is that
Okay.
specifically 1.6? Is that?
Well, it depends.
Yeah, there you go.
And it depends specifically on how old you are. So the prostate starts off pretty small, and as we go through life, we have the cumulative exposure to testosterone, the male hormone. And what that does is it drives growth inside your prostate. And that's why as we get older, the prostate gland gets bigger, and as it gets bigger, we end up with more urinary issues. It's why men get up more frequently at night when they're in their 60s or 70s compared to men when they're in their 20s. Now, as a byproduct of your prostate getting bigger with age, if you think there's a greater volume to your prostate, there are more prostate cells, and that means that there is more PSA that's produced. So as you get older, there is a higher level of PSA that we accept as normal. So for example, if you're in your 40s, most men will have a PSA of 0.6. So that's our median value. Now the threshold value when you're in your 40s is 2.5. So by definition we would say, well, your PSA is abnormal, it's elevated when you're in your 40s if it's greater than 2.5. In your 50s, a median value is 0.9 and the threshold is 3.5. When you're in your 60s, it's 1.2 and 4.5. And when you're in your 70s, that number is 2.5 and 6.5. So that reflects the growth of the prostate as you get older. So for you to say to me your PSA is 1.6, is that normal? I can't answer that because I don't know how old you are.
We fit to what the age grouping you're saying.
Yeah. Say again, I'm sorry?
It sounds like I'm 65, so that would fit that group.
So yeah, so then I would say a PSA of 1.6 when you're in your mid-60s is just above the median value and it's less than the threshold. So that your GP may relate to you and he may say, you know what, or she may say to you, it's normal.
That's right.
So there are different aspects to the PSA as well as the absolute value that we look at. We look at the median, which I've mentioned. We look at the free to total ratio. So this is kind of getting down to the nitty gritty, and what we try to do by looking at these different aspects of your PSA is try to work out, is your PSA value more likely to be produced by the benign enlargement as men get older, or is it produced by an abnormal growth? So a crude rule, the lower your free to total ratio, the greater the risk that you may have prostate cancer. The higher that value, the greater the likelihood it's produced by benign disease. The other thing that we look at is the rate of change of a PSA. So as I said, your prostate gets bigger as you get older. There will be more PSA in the system as you get older, but it should not change, should not go up by more than 0.3 in a year. If your PSA starts moving by, say, 0.7 or 0.8 in a year, then we need to start to look at that a little bit closer. So you could have a normal PSA, but if it's moving faster, that's another sign to be aware of. That's why it's really important to know what your number is, know what your PSA is. So have ownership of this prostate, of this issue, of your prostate. You know, when you talk to your GP and you get your results back for your various blood checks that you do, be aware of what the values are so you're in control and you can be involved in that process. Now, historically, with a PSA, if it was elevated and we were worried about the value, the next step really was for a man to have a biopsy of his prostate. It would be non-targeted, there would be no imaging to try to reconcile why the value was high, and the biopsy was done by placing needles through the valve. Problem with that, it's not targeted. There's a high risk of infection by placing a needle through the valve into the prostate. It caused a lot of problems. Men had infections of all different types, and there was a risk of not being able to pee properly afterwards. Thankfully, we've moved away from that process. And so now if we're concerned about an individual's risk of having prostate cancer, the next step is a scan, an MRI scan. So we'd be pretty fortunate in Australia. Some of the pivotal studies looking at the benefit of an MRI were done at the Wesley Hospital in Brisbane. And basically what we found over the years is that if we do an MRI scan, we can save a significant proportion of men have to lay the MRI on top of the ultrasound so we know where a particular area of concern is. And then we place a needle under guidance through the skin into the prostate to sample. So the advantage to that, it's more targeted, it's more selective, and the risk of an infection is almost zero. So I've been doing these sorts of biopsies by placing the needle through the skin since 2010 and have yet to see an infection. The standard way carries an infection rate of around 5 to 7%. So that's one of the subtle differences, certainly in terms of how we screen for prostate cancer over the last few years. So I'd encourage you all, if you all had a PSA test, know what your number is, discuss those strategies with your GP, and be aware of rate of change and the reference to other men in your age bracket and what actually constitutes the upper limit of acceptability. So that's how we screen for prostate cancer. I'm going to change tack slightly and talk about the enlargement that happens as we get older. And many of you may have experienced this firsthand. So as I said, the prostate starts off pretty small. It's always described, when you look at it and read it up in textbooks, it's always described as a walnut-shaped structure. The problem is, as we get older, testosterone has been around for a longer period of time, and the central part of the prostate is exposed to this hormone and proliferates. So the cells divide as you get older, so the prostate just gets bigger and bigger. The way I describe a prostate to most men, conceptually, is it's shaped like a donut. So there's a hole in the middle, and the outlet pipe of the bladder goes through the middle of the prostate, and that's how we empty our bladder when we pee. So if your prostate gets bigger, the space for the hole to pass through declines, and we end up with urinary issues. Now that's what this kind of graphic tries to represent. It starts off small on the left-hand side, and progressively we get enlargement until we end up with a really big prostate that's quite obstructed. Now what men tend to notice as they get older is they feel that their stream starts slowing down, and this happens really slowly and gradually with time, so it's a progressive change. Progressive changes are actually quite difficult to pick up on until things progress further and further down the pathway. But with a slow stream comes a longer period of time to pee. Some men say to me, geez, Charles, you know, I'm at the club with my mates, I go to the urinal and I'm there, and other folk, they come in and they go out, and they come in and go out, and I'm still there. Now with that slow flow and a prolonged time to pee comes some hesitancy, even when you feel like you need to pee, some intermittency, so it can be a little bit start-stop. And then what happens to your bladder? You'll see this on the next slide, is that your bladder, which is the pump, if you think of the bladder as the pump, so it's a muscular bag, it's a reservoir for urine, but it serves another function in that when it's full, it needs to empty. And to empty, it needs to contract. Now, if there's more and more obstruction below your bladder, it has to squeeze harder. So the process of doing that every time you pee, day on, day out, over the course of many, many years, your bladder, it's a bit like going to the gym, your bladder gets thicker. There's more muscle. You can see that, the change from left to right. And as your bladder gets thicker, it becomes stiffer. It loses elasticity. And with a loss or a lack of elasticity comes more rigidity. So there's a perception that you need to pee more frequently than you used to. It's accompanied with more urgency, and you get up more at night. And so men feel that their bladder is kind of shrinking as they get older. It's not actually. If anything, it's getting a little bit bigger, but it's the change in the wall that results in that increase in frequency. And the thing that the majority of men find most bothering is the lack of sleep. So that's the number one complaint that I see. Charles, I'm getting up more and more frequently at night. What can we do? Now, part of that problem is that men think that they've got prostate cancer when they notice that their urinary function is changing. And as you can see from that previous slide, it's the enlargement that happens in the middle part of the prostate that causes the blockage. Now, interestingly, prostate cancer tends to occur near the shell of the prostate. So in order for that to cause a man a problem, it needs to be really, really big before it will cause any compression. So prostate cancer tends to be a relatively asymptomatic condition. And that's why we need the PSA test. There's obviously a lot of conjecture, if you like, about whether or not men should have the digital test. Some men don't want to have it. There's lots of concern about having the test. You know, the problem with the PSA test is it can be high when there's no cancer, and it can be low when there is cancer. And having the digital test in combination with the PSA gives us a better handle on, is a man's PSA test appropriate for the size of his prostate, and can we feel any nodularity or any asymmetry or anything that is suggestive or concerning for prostate cancer risk. So how do we treat it? How do we treat when a man has bothersome symptoms from his big prostate? Well, to begin with, we go through a series of tests. We make sure, basically, that what we're dealing with is consistent with a big prostate. And once we've assessed and we're confident that the prostate is the culprit for why that man pees the way he does, funnily enough, there's a smorgasbord, there's an array of options. And ultimately, the decision about which choice to pursue comes down to how much inconvenience that man has from the way he pees. A lot of guys say to me, geez, Charles, what do you recommend? Which treatment do you think I should have? And so I always try to put it back on the man. I don't live with your symptoms. You do. You know how much it bothers you. You know how much it inconveniences you. And that should be the driver about whether you, A, have treatment at all, and if you do elect to have treatment, which treatment choice you're going to make. So traditionally, the simplest thing that we can do is put men on a tablet. And many of you may be on a tablet. There are simple tablets, Duodart, Flomaxtra, Minipress, Prazosin. And basically they work in slightly different ways, but they relax the prostate. They can give you a stronger stream, they can make you pee less frequently. The downside is you've got to take a pill every day. In a proportion of men, they'll give you a stuffy nose. They might make you feel a little bit lightheaded. The Duodart contains a drug that will shrink your prostate slowly, gradually with time. But the byproduct of shrinking the prostate is that it can decrease sexual function. So it can decrease libido and make your erections not as good. So if you're in a stage of your life where sexual function is important, not a great tablet to have. If you don't care less and you want entry-level treatment, that would be appropriate. But men do better with Duodart if they've got a bigger prostate, if they've got a slightly higher PSA, and they're a little bit older. Those are the criteria that I look for saying someone would be more suitable for Duodart than, for example, just having Flomaxtra. But part of the dilemma really comes down to the benefit that we want to have versus the risks from surgery. So traditionally, if a man had really bothersome symptoms and he wanted it to be improved, the choice that he had was to have medication or a TURP, which you may have heard of as the rebore operation or being reamed out. Basically, it was a procedure whereby prostate tissue was removed internally. So conceptually, a camera was placed inside a man's penis, up inside internally into the prostate. And remember the analogy I used of the prostate being shaped like a donut. We would go inside and we would scrape away, using basically like an electric knife, we would scrape away pieces of prostate tissue to try and make the diameter of the pipe in the prostate bigger. It's pretty effective at getting rid of overgrown tissue. Men can have a big improvement in the way that they pee. The trade-off, though, that the price that you have to pay is that men are catheterized for a couple of days. There's a significant risk of bleeding afterwards. There's a transfusion rate associated with that. And around 8 to 18% of men could have erectile difficulties afterwards. Now, just about every man after that treatment would have ejaculatory dysfunction, which means when he has a climax, no fluid comes out, it's dry. So that happens with pretty much every man after a TURP operation. So the science developed, and around 10 years ago, in this region, we had laser prostate surgery, which kind of does the same thing as a TURP, but it does it in a slightly more controlled way. There's less bleeding, there's less transfusion risk, you're in hospital for a shorter period of time, and there's a lower risk of upsetting your erectile function. But still, with any procedure where we remove tissue, it can affect your ejaculation. So again, for many men, ejaculation is an important factor, and they don't want to run that risk. So more recently, we've had the introduction of more minimally invasive treatments. Things like UroLift. UroLift basically is a staple system, is the best way to think about it. We can staple open the sides of the prostate. I've got a little video here, I think, of a UroLift. Basically, the sides of the prostate are stapled open. It pulls the overgrown tissue off the pipe. It can result in a big improvement in the way a man pees with no sexual dysfunction, so no ejaculatory nor erectile dysfunction. The trade-off is it's relatively new, and it's certainly not as durable as having the tissue removed. So you can see therein lies the trade-off. Some men would like a definitive treatment, and they say to me they never want to see me again, they want whatever's going to fix it for the longest period of time, they need to have a laser surgery. Other men who are concerned about sexual dysfunction, well, they need to have a more minimally invasive procedure, but they need to accept that there's a high risk that they may require to have retreatment. I don't know if that's... I'll try one more time. Let's see if we can get that to work. So this treatment is a combination. Is everyone all right to look at medical videos? I should have asked that question at the start. No squeamish people here? So this is a kind of a fusion procedure. So this man had, you could see the junction between his bladder and his prostate was really tight. So the first thing that we're doing is releasing that junction, allowing it to splay open, giving us a larger aperture between the bladder and the prostate. And once we've done that, the next step is to staple open the edges of where we've created to fashion a nice big opening in the middle of the prostate. So this is the urolith. This is that sort of medical stapling device I was alluding to. So the sides are stapled open to retract, to pull the pressure off the outlet pipe, to allow a man to have a stronger stream, to pee less frequently. And this type of approach is associated with a far lower risk of ejaculatory dysfunction. So again, if you don't care less about how your orgasm may or may not feel, you don't really need to have this procedure, and maybe you would want either medication or something that is more definitive and longer lasting. I'm picking up a few squeamish faces already around the room. Everyone okay? Do I need to fast forward? Okay.
How long would that procedure last for them?
So it's got about a 20% risk of retreatment at about 4 years. So 80% satisfaction, 80% of people still happy at about 4 years. So you can see it's not terribly long data, kind of short to medium data. But if someone, like I say, if someone doesn't want to entertain any risk of sexual dysfunction, that's a better way to proceed, as long as they're prepared to accept that they may need to come back for something else in due course.
Come back for that or something else?
Whatever they choose at the time. So we've kind of burnt no bridges, if you like, by that particular procedure. This video, this is showing the laser treatment. And so lasers delivered through this fibre. What it basically does is direct high energy concentrated light to the prostate tissue. It turns solid into gas, so we vaporize the tissue and we create a larger cavity. That really is showing you how we can perform this in a controlled way with far less bleeding. So that, if you like, is the modern way, or a more modern way that we would do the TURP operation, which was more mainstream historically.
How is that inserted?
Straight through the eye of the penis. So we have a telescopic camera, so we have a fine camera. These procedures are done under a general anaesthetic. People who have purely the urolith option are managed just as day cases. So they have the staples, they're in hospital for a few hours during and just after the procedure to make sure there's no issues, and then they go home later that day. They can experience some discomfort, some blood within their urine. Whenever we interfere with the system that's been blocked for a period of time, there will be, after treatment, a period where things are a little bit unsettled. And so men can expect an increase in frequency or urgency for the first week or two until things subside. In terms of other minimally invasive treatment options, something else that's just started this year really, the last 6 to 8 months in Australia, is something called Resume. I don't know if any of you have heard about Resume. It's the injection of steam into the prostate. Now, that is another treatment that aims to improve the way a man pees, but to do it in such a way that it interferes either in a zero or minimal way with erections or orgasm. So you can kind of pick up that the holy grail of treating a big prostate is to make a big difference in the way a man pees, to have it durable and long-lasting, and to not affect erections or ejaculatory dysfunction, and to be in hospital for a short period of time. And it's actually really, really difficult to achieve a full house. And when we get more minimally invasive treatments, we tend to compromise on durability. When we have maximally durable treatments, we tend to compromise on ejaculatory function, number 1, and erectile function, number 2, if it's with a T-blockade. And that's why we kind of tailor it to the individual, so a man chooses whichever approach he's more comfortable to pursue. But the resume, it's done again with a telescopic camera through the penis. We look inside the prostate and we inject steam into the prostate. And on average, we inject 4 to 6 little bubbles of steam. A man stays in hospital overnight with a catheter. He goes home with one for a few days. We take it out subsequently. Now, this one's a bit of a slow burner, so you don't really notice an improvement for about the first 3 weeks. You'd hate me for the first 3 weeks, why it's all a little bit unsettled. And then at the 3-week mark, we begin to notice an improvement. And we gradually get a steady improvement out to about 3 months. As I said, it's new. It's new to Australia. We've had it for no more than 8 months. And there is limited long-term data globally that gives us an idea of how durable it is. But certainly what we see are the numbers that are very similar to urolith, in that roughly about 15% of men would need something else to be done at about the 3 to 4 year mark. I was going to change tact again and talk about erections. I'm trying to cover it all tonight in one talk. So if people have got questions, would you like questions with each session?
Both the TURPs and the laser and the urolith, they all sound like, well, my imagination is you actually pee through a tube and that the tube goes through the prostate.
Yeah.
And all of those procedures sound like they totally destroy the tube.
Yes.
When it's within the prostate. So how should we cover
That's a great question. It's a really common question that I get. A lot of men say to me, well, hang on a minute, Charles. You're going to treat my prostate, but you're in the urethra, you're in the pipe. How do you get from the pipe to the prostate, get rid of the prostate tissue, and what happens to the pipe? So it comes back to, conceptually, think of the analogy of a donut. That the pipe that you're talking about is actually the middle lining of the hole inside the donut. So the pipe and the prostate are actually one in the same at that level. And so when we do a treatment, whether it's a TURP or whether it's a laser, whenever we're removing tissue, yes, we remove the pipe or the inner lining in the prostate. We get rid of the bulk of the tissue to unblock the bladder. And then what we see in the weeks and months after the operation is the lining of the bladder actually comes down inside the prostate and it resurfaces it. So we get a new urethra or a new pipe as it relines. And that process, as I say, just takes a few months afterwards. And men can notice after both of those procedures that they can have a discharge of some of the scab that can come away in those early weeks after surgery, and that is just a byproduct of the healing process itself.
Excuse me, guys. Can I just ask you, if you have a question, please use a microphone. Jeff or John will give you a mic. Otherwise, the camera can't pick it up. Can't pick up the question, only get the answer. Thank you.
Hello. Does that work?
You push it up.
Here we go. My name's Tony Flew. The last time I went to the doctor to have a general checkup, part of that procedure was that he suggested I have a blood test, and I said to him, "Don't forget to add the PSA test," which he'd done in previous years. And his comment to me was, "We don't do that anymore." I'd be interested in your comments on that, because my understanding is that, my understanding is that my understanding is that, and I've been to a few things with prostate cancer, that this PSA test was sort of a standard a checking ensure that your PSA levels were normal and suited your age and blah, 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 blah. So I'd be interested to get your comments from Tom and go back to my GP the next time and say to him,
So that question really was, if I can summarise it in a nutshell, is the PSA, is it worth the paper it's printed on? Is it any good? Is it beneficial in terms of trying to, ultimately what we want to do is save lives. We want to pick up prostate cancer at an earlier stage where it's more amenable to treatment, and we can allow a man to pursue his predefined longevity. He's going to live as long as he thought he was going to. So, as I said, as I said at the start, you will get a different opinion, as you have done, from a general practitioner, in part because of the guidelines that their college advocates. You'll get a different answer than when you talk to a urologist. Now, part of that disparity stems back to a publication in the New England Journal of Medicine, so a medical scientific journal. And back in 2009, there was a publication that looked at the benefit of a PSA test. And it was done in America. It was called the PLCO study. And they randomized hundreds of thousands of men to either have a PSA test or basically nothing. In those days, this was recruited in the 90s, and their standard of care was supposed to be no PSA test. And the publication basically said, you know what, there's no difference between the two groups, it's a waste of time, don't have it. But when you pick out the details of that study, what you realise is that there was the control group that was supposed to have no PSA test, but in actual fact, 90% of those people had had a PSA test either just before or during the course of the study. And so what you were comparing was a more heavily PSA tested or screened population to a slightly less PSA screened population. So the study was flawed. Now, around 5 to 10 years ago in America, part of the issue is that men that were diagnosed with non-aggressive prostate cancers had treatment. Now, by non-aggressive prostate cancers, some of you may be aware that when we have a new diagnosis of prostate cancer, 3 things that we look at to work out what type. Your PSA, how your prostate feels, and the Gleason score. Now, the Gleason score is pivotal in determining, is that disease going to behave in an indolent way, i.e. never cause that man a problem, never grow, never spread, never shorten his life. And if you've got a Gleason 6, the likelihood of it ever causing you a problem is pretty close to 0. But the problem is, in North America, what happened is that there are thousands and thousands of men who had Gleason 6 and they had surgery, or they had brachytherapy, or they had radiation treatment. So you've got this enormous cohort of men who had treatment for a disease that was never going to harm them, and they're so-called cured from this disease, but they end up with the potential side effects of erection difficulties or urinary issues. So we had this study that said it was no good, and at the time men, in my opinion, were being over-treated in America, and that's what has tainted, if you like, the prostate cancer landscape. Now, at the same time that PLCO study was being performed in the States, there was a European study. It was across several different countries, so it was international, it was multi-center, and they did exactly the same study. You had a PSA test, and we compared it to not having a PSA test. And the difference between Europe and America is, in Europe, the men that were supposed to not have a PSA test actually didn't have a PSA test. So the contamination was very, very low. And what they found was that the longer you followed these men up for, actually you started to save lives. And so when you went beyond 7 years of following up men after the time that they had a PSA test, there was a survival advantage to having that PSA test. So when we talk in medical circles about evidence, level of evidence to back up a particular practice, for having a PSA test, there is the best evidence, level 1 evidence that supports that we can save lives if you have a PSA test, and we can also decrease the likelihood of being diagnosed with metastatic prostate cancer, disease that has already spread beyond the prostate cancer at the time, beyond the prostate at the time of diagnosis. So recently, in America, they have a disease preventative task force. And on the back of that PLCO study, they actually said, you know what, no one in America now from 2012 should have a PSA test. So they stopped doing it. And what they found is that the number of men that were diagnosed with metastatic prostate cancer and the number of men being diagnosed with more aggressive prostate cancer was heading back to the pre-PSA era, what we had in the 1980s. Now, at the same time, the Americans began to pick up on what is a standard practice here in Australia and New Zealand, which is active surveillance. And active surveillance means that when we find someone who's got a Gleason 6 prostate cancer, we don't treat it, we watch it. And we watch it with blood tests, and we watch it with MRI scans, and we've got biopsies as a backup if there's any change to those parameters. Now recently, going back about 18 months, the Americans changed their minds again. And they said, you know what, actually, we may have got this wrong, and we think that men should have a PSA test. And so now the consensus in America, as is the consensus amongst urologists here in Australia and New Zealand, and also the consensus in Europe, is that if you are proactive about your health, if you're between the ages, and here's their guidelines, between the ages of 50 and 70, and you want to be proactive and assess your cancer risk, your prostate cancer risk, have a PSA test. But what I would say to you is if we have someone who smokes 20 ciggies a day, if he eats poorly, doesn't exercise, if he's overweight, if he's got heart problems and diabetes, if he's likely to die from a whole host of other conditions, well then you need to weigh up the pros and cons of having a PSA test. But part of the issue we have is that the College of General Practitioners currently advocates that having a PSA test causes more harm than good. But the evidence doesn't back that up.
Thanks, Charles. You said that the PSA and digital test is standard practice. Under what circumstances would a Gleason test be done? And the second part of the question is, to what extent does the government health scheme cover any sort of surgeries that you might want to have done?
So the first part of that was a PSA test and a digital test is standard of care. It's standard of care if you go and see a urologist. Many general practitioners perhaps are not familiar with doing the digital test, and so they may not offer that for you. I think with any test that we as doctors provide to our patients, we need to be familiar with that test and we need to be able to interpret the results of that test. So, you know, my GP colleagues, if they don't want to do it, if they don't do many of them, I think it's entirely reasonable to not do that test. But if you want to be assessed appropriately, go and see your local urologist and have that assessment. The Gleason score, I think, was the next part of that question. The Gleason score is a number system that's given on the basis of a biopsy. So if we do get a tissue sample of the prostate, if there's a target lesion, for example, and we put a needle in it, we get some tissue, we send it to the lab, the first thing that they will say to us is yes or no to the question of prostate cancer. If they say yes, and they're saying yes, there is prostate cancer there, then they will grade it for us. So they will let us know how aggressive it is. And that's where the Gleason score comes into play. So the original score that was described about 30 to 40 years ago went from 1 to 5. And the sum, and it is the sum of the two most common patterns that give us a score. Nowadays, we only see a range from 3 to 5. So the least aggressive form of cancer is that 3 plus 3 equals 6, meaning all of the disease is pattern 3. The most common type of cancer I will see is a 3 plus 4 equals 7, meaning most is pattern 3 and we have a smaller amount of pattern 4. Final aspect to that question was how much does the government cover for various prostate cancer treatments? That's an open-ended question. It kind of depends. So if we look at the whole array, a PSA test, 1 per year is covered unless you've got prostate cancer. If you have prostate cancer, multiple tests are covered per year. The change in the budget this year meant that for certain criteria, the MRI scan became covered. Historically, and we've had MRIs for around 5 years, there was no coverage, and so men would be out of pocket for the tune of around about $500. In terms of treatment costs, you know, there's a Medicare a component to any treatment. There is a component that may be provided by your healthcare, and there will be a gap component as well. So that depends on the individual circumstance, your health fund, and where you go for treatment.
You've kind of answered the question of...
Oh, okay.
Any other questions, gentlemen?
Bamboozled.
Yeah, next section.
Next section?
Yeah, my name's Barry Woodbury. I'm curious to know that is there any exercises that men can undertake that limit the possibility of prostate problems? And also, is there, would you recommend any certain diets at all?
Okay, so two questions. Is there anything we should be doing to improve the health of our prostate from an exercise perspective? And number two, dietary modifications that can decrease prostate cancer risk. Certainly if we look, prostate problems per se, you know, there's very little that you can do from an exercise regime that's going to alter the potential growth of your prostate. You know, there are pelvic floor exercises, which actually they're not going to change what your prostate does, but I think they're really important to maintain a healthy pelvic floor. You know, we've got to remember that the erectile tissue stems from the pelvic floor, and if you've got a strong pelvic floor and a good core, your urinary control as you get older is likely to be better, your sexual function is likely to be better, and if you do need to have any kind of prostate intervention, you're better placed because you've got a stronger, healthier pelvic floor. You've got to remember that as we all get older, our muscle mass declines. So we tend to lose muscle bulk, muscle strength, muscle tone everywhere in our bodies as we get older. And so it's really important to incorporate regular exercise into what we do, together with a healthy diet, to try to prevent a whole host of things. You know, I'm often asked that dietary question. You know, we look at the most common conditions that we face here in Australia in terms of shortening our longevity. Cardiovascular disease, cerebrovascular disease, obesity is on the rise, type 2 diabetes is on the rise, and there's a whole host, from that slide that I showed you at the start, there's a whole host of cancers that we're seeing. If we look globally, the incidence of prostate cancer in Australia and New Zealand is amongst the highest in the world. You've got to say, well, why is that? Well, there are two triggers for various cancers. There's your genetic predisposition, so what you're born with, and you can't really do a great deal of that. But then there's pulling the trigger on your genetic predisposition. And what we do in the West is have a diet that's pretty poor. And our diet over here contains a lot of animal protein, a lot of saturated fat, and it's low in fiber. So the best diet, if you like, contains low animal protein, low saturated fat, and high fiber. The WHO, so the World Health Organization, came out a few years ago and they said, you know what? They're going to put processed meat in the same category of carcinogen, the same category as chemical that can provoke cancer as smoking cigarettes. So that's your bacon, your sausages, your ham, your salami, all of that. There's an established association, and this is what kind of shoots us in the foot. We all love to barbecue, but high temperatures on a barbecue, and particularly red meat, is associated with an increased risk of developing a variety of different cancers. But exactly. That's the problem.
I entirely agree with what you said. I'm a prostate cancer survivor for 14 years.
Excellent.
And when I was younger, I was abusing the body, and I was overweight, did lots of things. I've now had started with radiation therapy 14 years ago. My cancer came back after 10 years. I'm now having hormone treatment. I've now been told by my oncologist I can have a couple of treatments for $40,000 or go to America, which has escaped a little bit. I'm extremely healthy otherwise, and I wished I'd been like this 30 years ago instead of whining and dining and all those things that you said. In my situation, you know, do I wait and see? My father died from prostate cancer. I'm 80. He got it in his 80s. He lived till 86. He didn't correct him. I'm just on the fringe of having further treatment. And I think that I will go the way and probably have the other common treatment, even though in my prostate support group I'm having double lots of hormone. The other guys are the same treatment. They have skin irritations and they have giddiness. I still drive a car, but I'm extremely active. I watch extremely what goes in the cake hole because I was a dentist, so I realise, you know, I don't need any fats or anything like that much now. And I believe that, you know, I just keep on going the way I am, or do I have more treatment? Thank you.
I mean, I can't answer the question about should you or should you not have more treatment. That's very much an individual one. But look, you know, if you remain well and active and engaged in life, my opinion is that you do what you can to continue on living and enjoying your life, if that's what you do, you know. So yeah, I mean, if there are treatment options available to you, I would certainly be looking and be open to those avenues, for sure.
This question's more out of curiosity. I notice in winter, most men pee more frequently. I don't have the same problem in summer. I was just wondering if you can explain that.
Yeah, sure. So look, the question really relates to environmental factors that trigger bladder frequency. And so what's happening, and it's very common in men who have had prostate treatments, in men who have not had prostate treatments, but by the time we get to May, and from May through to about the end of August, I see an upswing in what I call irritated voiding symptoms. We've got two categories. We've got the irritated ones, which are due to your bladder. They're the frequency, the urgency, i.e. I need to go to the loo, get out of my way, I'm on my way, and getting up at night. And the obstructed ones are the slow flow, the hesitancy, takes you a long time to pee, feel like you're not emptying properly. Now what happens, and it can be if you turn on the tap, it can be if it's cold and windy and rainy, it can be if you stand on cold tiles. Basically it's an environmental trigger that causes a contraction in your bladder. And when your bladder, which as you remember is a muscular bag, it contracts, the pressure shoots up. And when the pressure goes up, even though you may not have a lot of urine in your bladder, you feel like you need to pee. So that's the kind of the basis of that. You may notice it in the guys on the golf course here. You might notice when you're playing in the middle of July, you may need to pee 2 or 3 times in a round, and in January, you may not need to pee at all. Part of that can also be related to hydration too. You know, in January you're going to lose a lot of fluid through perspiration, whereas in the colder months that's less likely to happen. Now's your time, gentlemen. Get your questions in. I think I've got about 3 minutes. I've spoken for almost an hour, so anything you've ever wondered about the ways of the prostate? Here we go.
I don't know where you're. Oops. When I went for my checkup a few years ago for my GP, this sounds terrible. I said about the examination, he said, have you had those symptoms? I said no. He made the comment, a lot of men die with prostate cancer, no one's ever died from it. Guess what he didn't tell me was that it goes somewhere else, doesn't it? It's a funny thing for a doctor to say that.
Yeah, that comment really is, it's a historic comment. Many men die with prostate cancer rather than from it, and that was the historical norm. And what that comment underpins is that as we get older, the risk of developing prostate cancer is greater than it is when we're younger. What we're trying to do with the examination and the blood test is to pick up significant prostate cancer that has the ability to grow, to breach the shell of the prostate, to spread elsewhere, and ultimately to shorten your life. That's the type of prostate cancer we want to pick up on early so we can intervene and prolong life and decrease suffering. As we get older, prostate cancer is more common, but the types of prostate cancer that we don't really want to find, which is the one that you die with rather than from, is the Gleason 6. So all prostate cancers are not equal. We don't want to find the Gleason 6 because we're not going to intervene if you have a Gleason 6, because the likelihood of that growing and spreading and shortening your life, as I said, is close to zero. So it's about being aware that there are different types of this disease, and we're trying to pick up on the bad guys, basically, that are the cause of problem. So that comment that your GP had made to you previously is very much a historical one. We don't want to find that type of prostate cancer that people die with rather than from, because we're not going to treat it.
My name's Derek. I was just wondering, question, does it have anything to do with the amount of times you use it? If you use it less, have you got more chance of getting it? If you're using it a lot, is there less chance? Is that measurable?
Do you know what, there was a study from Harvard University that looked at that frequency of ejaculation per month, and what they found, here's a crazy figure for you, that if you ejaculated 21 times or more per month, your risk was lower. 21.
So the less you do it, the bigger chance. The less you can do it, the greater chance you may have it.
Well, the more you do it, it would appear, and this is not conclusive, although I think everyone here would like it to be conclusive data, but it would appear that frequency of ejaculation obviously results in emission of ejaculatory fluid from the prostate, so it empties more frequently. Now, with different cancers, there appears to be an association with inflammation. So inflammation is kind of relatively new, and in terms of our understanding of how different cancers develop. And so, now this is not proven, but it would appear that with frequent ejaculation, there isn't the stale fluid around to potentially become more gluggy and initiate an inflammatory response, and thereby potentially decrease the risk of developing an abnormal growth. Not conclusive, but that would appear to be the potential pathway.
I was going to say,
You need a script, guys? You need a script.
I've been told.
Don't know, everyone's going home tonight and they're saying, honey, you'll never believe what the doctor said. He said it, not me.
Do I understand that if you are on a Gleason 6, if your score is a Gleason 6,
Yep.
you're likely to stay on a Gleason 6?
Okay, so that's a great question. So, question basically is, if you're diagnosed with prostate cancer and you are diagnosed with a Gleason 6 prostate cancer, basically the question is, is it always going to stay a 6? Or if we watch it for a while, will it turn into a 7 and an 8 and a 9, and then will we have problems? The short answer is it will always stay a 6. The biology of a tumour is what the biology is right from the inception of that tumour. What we have to do right at the very start of the diagnostic process is to make sure that we've got it right. And the issue is that with every test we do, whether it's a PSA, a digital test, an MRI scan, a biopsy, a PSMA scan, all of those things have the potential to get it wrong. They can be falsely positive, they can be falsely negative. So what we try to do when we start off with our new diagnosis is to make sure that our margin for error is as low as possible. So we make sure, for example, that the MRI scan, if someone has a Gleason 6, I would expect their MRI scan to be normal. If they have a spot on an MRI scan that's suspicious and they've got a Gleason 6, immediately for me, 2 and 2 is not making 4, and so I want to try and reconcile the difference between those two things. Because when we put someone on active surveillance, we need to be pretty confident that what they've got is a 6. But every now and again, we do see that when we do our checks subsequently, and to give you an idea, when I look after someone with active surveillance, they're diagnosed, we do a 6-monthly PSA. At the end of the first year, I like to repeat the MRI scan to make sure there's no interval change, no new lesions. And at the end of that first year, I'll usually repeat the biopsy to make sure it's a 6. If there are changes at that time, well then we reevaluate and we have a discussion about what we've got at the time. If we still have a Gleason 6 at the end of the year, then I'd say to that man, you know what, we're pretty safe to not be doing these biopsies, and we keep going with an annual MRI and a 6-monthly PSA. But a 6 does not go to a 7, does not go to an 8, and so on. You've kind of got what you've got from the start of that tumour. But the key with our diagnostic process is really to make sure that what we've got is what we've got.
This one's not quite as tricky. If you start off with the nut, the small nut that grows, at any stage you come in and actually remove the nut.
Say that one more time.
As you said, when it first starts, you have a small nut, and the nut enlarges.
You're talking about a testicle or a spot inside? So I just had to clarify that. You're talking about a small spot inside the prostate?
Yes.
Okay.
Do you actually remove the, as you said, the nut gets bigger. Do you actually physically remove that?
So we're talking about cancer or the benign enlargement? Because the two are very separate. So if you have benign enlargement, the prostate gets bigger, the bit in the middle, and if we're going to treat that, yes, we go in there and we get rid of the enlarged part. It's called the adenoma. We get rid of the blocking component to free up the pipe and make a man pee better. If it's a cancer spot, the way that we treat it, the established ways to treat it, surgically to remove, different ways to do that. Brachytherapy, where we put radioactive seeds into the prostate, or external beam radiation. The 3 established ways. There's one surgeon in the world who has tried what you just said, who's tried to cut away just the lump. He did it on 12 patients. Poor outcomes. Part of the problem is that with prostate cancer, it's a field effect. So whatever has triggered the change, has triggered the change across the whole prostate. We are seeing more and more with MRI scans that there tends to be, not always, but there tends to be one particular target lesion. And so newer treatments are looking at trying to have focal therapy, i.e. keep your prostate and just treat the one spot. People have looked at freezing it, at cooking it in different ways, putting electric current through it, trying to burn it. They're experimental because we don't have long-term data to back them up. They tend to have been used for individuals who perhaps you may otherwise not treat, but that individual wants to have treatment. So for example, a man approaching his 80s. And to get the benefit, why I say the 80s, because to get the benefit from treating prostate cancer, you need to live at least 5, ideally 10 years from the time of your treatment. So in those older men who may be a little bit more anxious and they want to have treatment, they can maybe have focal therapy on the understanding that if it doesn't work, it's not going to have a big impact on their overall longevity. But for your average man who presents or is diagnosed with prostate cancer and the peak age of diagnosis is 65, those men really need to be treated with established treatment choices.
I had robotic surgery about 4.5 years ago, and the prostate totally removed, and my PSA was still very low at 0.049, right? And I wanted to get rid of it altogether, if possible, so I went in for a 7-week radiation course, and it's starting to drop down to 0.039. Now, is that exactly a high rate or low rate, or should I be concerned, or with it going down to see what happens over a long period of time?
So that question really is about the rate of change of your PSA if you've had your prostate removed and you have radiotherapy.
That's right.
Okay, so the short answer is that with radiation, it causes its effects slowly and gradually with time. So with surgery, you're in and you're out, it's treated. What happens immediately. So for example, with sexual function, you have erections before surgery, you have your surgery, your erections go, we try and recover them with time. With radiotherapy, the majority of men tolerate radiotherapy pretty well for the first half of their treatment, and then in the latter half, that's when any potential side effects can kind of creep in. A bit of fatigue, a bit of nausea, a bit of vomiting, and bowel and bladder related changes. In terms of PSA changes, we can expect a gradual decline for about 6 to 12 months after you have treatment. But if we take a step back, it is your final pathology when you have your prostate removed that is the single most important predictor in terms of how you and your disease are going to respond to a single treatment or multiple treatments. So you need to know your Gleason score, how much disease, did it breach through the shell, did you have a positive margin?
It was an external tumour,
Right.
and I had 20 needles put into the prostate to test it. 17 were non-cancerous, 2 were low cancerous, and 1 was ballistic. And when the test came back, it was extremely, extremely dangerous, the tumour that I had. And that's...
Well, when your prostate was removed, so the final lab test, not so much the biopsy when you had the 20 needle samples, the final biopsy when you had your prostate removed, that goes to the lab. And that is the final and the most critical piece of the puzzle.
Yeah, well, it came back as they think they got it all, or came back that he took more than what he usually does to make sure he got it. But since then I've had leakage problems and so on. Is there anything that can fix leakage problems except exercise?
Oh yeah, there's several things. So yes, number one, exercise, and specifically pelvic floor physiotherapy, targeted exercises are key. There's a great video on my website by a guy called David Hughes, who's a prostate cancer support nurse. He's based down in Lismore. He's a great guy, but there's a 15-minute video on my website, on the YouTube channel, and he teaches blokes how to do pelvic floor exercises.
So I've seen that 2 days ago.
But you've seen, okay. Well, I think that's a great video, and I get a lot of feedback that it's a good video. I always recommend to people, do what Dave teaches you to do in that video. If you're a year down the line from your surgery, if you haven't had radiotherapy and you're a year down the line, the way that we manage that depends on how much leakage you have. If you're leaking maybe 200 mils, 250 mils in a 24-hour period, if you can interrupt your stream, and if you're dry when you lie flat, you go to bed at night, a sling is a great option for that man. If you've had radiotherapy, if your leakage is a little bit more, if you cannot interrupt your stream, if you do have some leakage when you lie flat at night, you're better off to have an artificial urinary sphincter, which is a cuff that we put around the urethra. which is a cuff that we put around the urethra. And it's an inflatable cuff that clamps down on the urethra, so it causes a physical occlusion. Keeps men dry. You control it through a little pump that sits in the scrotum underneath the skin. Your bladder fills, you stay dry. When you want to pee, you reach into your scrotum, you hit the button, it deflates the cuff, and you pee. So those are the two established treatments. A sling for more minor incontinence, less effective.
Is that an operation, sling?
Yeah.
Right, thank you.
Charles, I don't think there are any more questions. Are there any more questions at all? There's just one question.
There's one question here.
One question here.
Wants to know what happens when you remove the prostate. If you can, what happens?
Okay, well, so I guess different ways. You know, people talk about removing the prostate. If we remove the whole thing, when someone's got prostate cancer, you remember what I said, that the prostate is responsible for the fluid that you see when you ejaculate. Just about all of it comes from the prostate and the seminal vesicles, which are like little reservoirs that sit on the back of the prostate. If we take those away, you have an orgasm, it's dry. No fluid comes out. Permanently dry. Because of where the prostate is, to remove the prostate for cancer, the muscle that keeps you dry, the pelvic floor, can be a little bit bruised. And so many men will experience urinary incontinence. The majority of them experience it for a few months post-surgery. The minority have issues longer term. The nerves that supply the penis that allow a man to have an erection are kind of plastered on the back of the prostate. And so depending on the disease features that a man has, those nerves can be spared. And if they can be spared, we have a chance of getting erectile function recovery. But we need to be proactive with Viagra-type tablets and so on to facilitate that recovery. But as a long story short, remove the prostate, a dry orgasm, maybe issues with urinary control, maybe issues with erectile function.
Thank you very much.
Charles, I think that's just about it. It's now 7:15. You wanted to go at 7 o'clock, so I think you've done very well, don't you, gentlemen? Charles. If you will,
Just a little thing from us. Thank you very much.
thank you.
Thank you.
We got it.
Thanks very much. Cheers.
Thanks so much. Gentlemen,
You're welcome.
if you will, we'll just see Charles out the door. Make sure he leaves the building. But as well as that, I'd like to mention to you also that tonight is 2 for $25 downstairs. They are expecting us for dinner. I would suggest that we put away the chairs and everything else and then go down and have some dinner. Okay. Thank you very much.
Thanks, Well received.
Didn't know what to
Last You get a couple of answers, I hope you did.